Let me just remind you of some very important clinical rules we all have to follow. And they come from The House of God by Samuel Shem. You know, at a cardiac arrest, the first procedure is to take your own pulse. The second one is very important to remember. The patient is the one with the disease. And the best delivery of medical care is to do as much nothing as possible. But what I think is important in this context is if you don't take a temperature, you cannot find a fever. And we've heard a lot this morning about renal monitoring, for example, and some people simply are not doing the correct tests to detect the problem. So I think this is really an issue of monitoring, and this has been addressed by the European AIDS Clinical Society in a very thoroughly elaborated guideline which you can look up in detail. I'm not going to go into the details of that because that's the current recommendation status. And this affects different organ systems with which we see complications in our patients arising, both with respect to comorbidities and also treatment-related complications. Please look it up, but it sounds, or it appears very scattered because you find all the different areas and organs. And I've tried to go through, why are we actually doing all this? So what are the questions behind all those monitoring recommendations? I think one of the questions is, how urgent is ART in an pre-treated patients at HIV diagnosis? We usually follow the clinical symptoms in opportunistic infections. We know this is an urgent treatment. But with respect to the urgency, I think CD4 cells still give us a very important information, as well as thrombocytes in the blood picture if patients have immune thrombocytopenia. The second aspect is how dynamic is replication. People with a low viral load have a relatively low progression of immunodeficiency in the next time. They might have on a long run, they might have clinical progression, but short-term progression with respect to CD4 is usually relatively low. So that is an important information. How infectious is the patient during acute infection or later on is another important aspect of viral load. So I think this is all going to be it's going to stay within our diagnostics in the future around the time point of diagnosis. And the other question that we want to have answered is, are all regimens potentially effective enough? And for that, we know high viral loads are associated with failures of some drugs. Low CD4 counts are associated with failures of some regimens, as for example shown in the NEAT-01 study for boosted darunavir and raltegravir with low CD4s and a very high viral load. And resistance analyses are important, I think, and will remain in the primary diagnostic in the future, because with more extensive use of the drugs, with people coming in from developing countries where resistance is very common, we might see more of resistance in the future. And the next question would be, is a drug too risky? We've seen that renal monitoring is important, and we've also seen that renal risk assessment is important. Liver enzymes with respect to toxicity of some drugs, cholesterol, cardiovascular risk, blood pressure and glucose, and fracture risk or bone marrow density, as well as a very specific test belonging to the classical HIV diagnostic armamentarium, HLA-B 5701 for abacavir hypersensitivity, as well as a problem that we need to address would be pregnancy test. For women, it could be risky to expose them to some drugs in early pregnancy, or at least for the baby. And the next question would be, around the time point of diagnosis, are there HIV-associated conditions that need to be treated in parallel? And for that, we have some monitoring tools to assess if there are undiagnosed opportunistic infections that we might have to address in parallel with ART, and we might even withhold ART for some time in people with cryptococcal meningitis or TB meningitis. And are there HIV-associated conditions that need to be prevented in parallel? For example, with a low CD4 count, which would trigger our initiation of anti-infective prophylaxis for PCP, toxo, or even MAC, although this is a matter of discussion right now, or even cryptococcosis in some areas, I think a problem that isn't really addressed by many clinicians would be the risk of reactivation of latent tuberculosis and INH prophylaxis, or chemo prevention. The next question, and it's all to explain why we have this extensive list of tests to be done at diagnosis. Are there comorbidities that have to be treated in parallel? There would be HPV, HCV, syphilis, gonorrhea, all the STIs, as well as metabolic diseases and also cancer. We need to screen our patients for anal cancer. And monitoring, if I talk about it, is more in a general sense. It's not only performing lab values, it's looking at the whole patient. And the next question would then be, are there comorbidities that have to be prevented in parallel? And also there we have to try to see if people are already immune against hepatitis A, hepatitis B, or if we have to vaccinate them and protect them from that. And also if they have a higher risk of developing osteoporosis due to a low vitamin D status, as is the case for example, many people with a darker skin pigmentation who live in areas of the world like our country where there's not so much sun. And very regularly the patients have vitamin D deficiency. Actually, that's 80% of the population in Hamburg who have vitamin D deficiency, so that's because we live our lives mainly under electrical light, not under natural light anymore. HPV screening also is, I think, an issue that is arising, although still the risk is relatively low per individual, and the number of cases of anal carcinoma that develop are still relatively low, but it's clearly increased in our patients. And sometimes a simple look into the anal region or a digital examination could be enough to detect a tumor. I think what would be ideal would be novel ways of monitoring, like high resolution anoscopy. And then we get into follow-up. People are then treated, and what do we end up with as diagnostic tools in this phase? And we see that I've marked all the HIV-specific parameters in green. You see that HIV RNA, that is definitely the thing that we need to continue in the future. We need to ascertain that HIV is really suppressed on treatment. And if people have a rise, confirmed rise to greater than, for example, 200 copies, we need to do a genetic resistance analysis. This has not changed, and it's not going to change, I think, in the future. The next question, very important for patients, is, in order to communicate that, is HIV RNA, what does it tell me about infectiousness? A very frequent question in my practice. And also CD4, I think, for some time into therapy remains important. We are used to determining it every 3 to 6 months right now, but you could argue that once people have reconstituted their CD4 counts to high enough levels to be out of the danger zone for many diseases, you might really argue for leaving away CD4 count measurement to streamline the diagnostics, because sometimes it's very annoying for patients to see them bump up and down due to their variability. And then we get to the very important point, I think, which is a very important point for many people currently under care, and that's going to be increased in the future as well. If we have to switch from one regimen to the other, for whatever reason, we need to know if we can do this safely without risking viral suppression. And I think what we are actually lacking right now, we have data, maybe, if we're lucky, on historical RNA. We have historical resistance data if we've got access to that, but in many people we won't have that. So we need, and this is a quest to the virologists, we need to establish methods to look at archived resistance in people with non-detectable viral loads and find that in a sensitive enough way to make predictions for the next regimen. I think, Jonathan, you probably agree with that. I think that's a real challenge because it affects a lot of patients. And then one of the questions that is, you've seen that in previous presentations as well, is there ART toxicity? Another reason why we're doing renal tests, creatinine. You know that creatinine increases in people on cobicistat or rilpivirine or dolutegravir. So this, in a way, blurs the picture of the clearness of renal function, and we might sometimes need to use cystatin C in people in order to just to find out if this is really renal impairment or if this is just an effect due to the blockade of active tubular secretion of creatinine. I've listed some other parameters, but the next question would then be, is prevention of comorbidities successful? We need to control if our vaccine measures were actually effective. If not, we need to revaccinate. So this would be another part of optimization of monitoring for the future in order to protect our patients from these infections. We have an hepatitis A epidemic right now among HIV-positive gay men going on in Berlin and spilling over to my home country. So we need to ascertain that people are really immune. And we have to we're looking at a population, at least partly, with an especially high risk of sexually transmitted diseases, and we have the unique access to these patients and can really do screening for all those sexually transmitted diseases. So this needs to be clearly and routinely embedded into our monitoring overall monitoring strategy. And the last question then is, is there new comorbidity that arises while we are treating the patient successfully? And that is the classical spectrum of comorbidity with regard to metabolic diseases or cancer that could come up. And we have to remember we mustn't forget the screening for the diseases that we would screen other people for if they were not HIV infected. So just examples of, you've seen these slides, and I won't go into the details, but what I wanted to list them as brief examples of the monitoring of drug-related toxicity. So we have to know, are we using TDF, atazanavir, lopinavir? If so, we need to be aware of the renal risk, and we have to monitor renal function. As we can see, you've seen that already this morning, the association with progression to an eGFR of less than 60. But darunavir was not overtly associated with this decreasing eGFR, so it's actually drug-specific. And it's going to be very difficult to develop a uniform screening program and monitoring program for our patients if we do not pay attention to their individual risk profiles based on their individual risk constellation, plus the drugs that we are giving to them with their individual risk profile. You've seen this slide already, just again to show that if you have new drugs that circumvent some of the issues, like TAF seems to circumvent the issue of progression of renal deficiency or renal insufficiency with TDF, we might get around some of the monitoring things. So in somebody on TAF, it probably doesn't make sense to monitor creatinine as frequently or to monitor tubular function as frequently as we've done it in the past and tried to detect the problem while it was still of minor importance. And this is, again, just an example in people grouped according to a high risk that was calculated along the Copenhagen HIV program, chronic kidney disease score, high score people, medium score people, and low score people. You see that all of those had, in red bars, had higher tubular proteinuria with TDF and had no relevant proteinuria with TAF. So this, we probably could, I'm saying this a little provocatively, we might give up doing monitoring in some people with a low risk of these highly specific parameters. And that's going to help some of us because we didn't have access to those sophisticated tests anyway. If it comes back to Samuel Schem's remark, if you don't take a temperature, you cannot find a fever. So if you don't measure that, you will never find it. And depending on what you take, urine albumin creatinine ratio, you won't detect or just have a minor detection of low molecular proteinuria because albumin is, to some extent, is also actively secreted to a minor extent. If you take protein, you'll have all the proteins comprised in what you're analyzing, and this might be among them. You have to know, I think that's one of the lessons also, precisely what your tests tell you. And the same applies to bone mineral density. We're discussing a lot of issues around TDF-associated loss of bone mineral density. I mean, you've heard these presentations before. But if we use drugs of minor toxicity, we might get around this issue and see an increase if we switch people away. This is a switch study in people with renal insufficiency. There's another aspect of that. If we're looking at drug-related toxicity or if you're looking at drug-related risks. And I'm trying to convince you that in the future we will talk more about risk management than about disease management. And this is about managing risks. You might believe or not that abacavir is associated with increased cardiovascular risk. There's a lot of cohort data to support this, but there are other cohorts contradicting this. But you have to deal with the thought that if this is true, what do I have to do in my patient? If I have an alternative, should I maybe select something else? If I have no alternative, the question is irrelevant. We now have the impression, I think that's the first cohort data that shows an increased cardiovascular risk for darunavir as well. It's not yet confirmed, but I think it will be confirmed. My personal view is that would be very logical. You see on the right-hand side that in contrast to tazanavir, there seems to be an association. We have to factor this into a risk management strategy. And if I say monitoring, this includes assessing the risk and calculating the risk and adding a little bit of risk, for example, in this case, about 50% per 5 years of treatment for darunavir. We have some other toxicities that do occur. We see increased suicidality. This is a wide definition of suicidality. In this case, in the start trial arm randomized to efavirenz, and we see that in the immediate arm, when people were assigned to efavirenz by the investigator, there was an increased risk of suicidality, especially for people with specific characteristics, and not in the other with the other treatments. But how do we actually measure that? Are we certain that we will always capture this in our clinical routine? Are patients going to come in and tell us, "Listen, I'm thinking about committing suicide"? I think this is not going to be the case. So we have to make up our minds. I have no clear idea about this, although I know there are instruments of assessing suicidality. We have to make up our minds in the next 10 years if we want to approach a more standardized way of capturing subjective toxicities. What we know is we could either, as proposed today, group Europe very simply into, let's say, on the right-hand side, for example, olive oil Europe or butter Europe, and classify cardiovascular risk according to that. Or we could say, let's take another classification. We have vodka Europe in the north, we have beer Europe a little further down south, and we have wine Europe down south. This is a great thing. I want to point your attention to Janko Tsevskov's Atlas of Prejudice, if you're interested in that, tearing Europe apart. But you could do it in a more rational way, and as has been proposed today, you could use the Framingham score, which is tailored to an American population, a more historical one, does not take into account HIV-related risk increases. You could look, if you're from the UK, you can use the Reynolds score. But you could, especially if you come from a country in Middle or Eastern Europe, you could go to the EACS score, which gives you the mortality estimate for cardiovascular disease, because there is data included from cohorts from those countries, in contrast to many other of those. Or you could go to CHIP, which includes data as well from Eastern European countries, and have a special estimate that takes into account HIV, which I think is very, very good and very useful in our hands, because generally if you calculate that, you get this in parallel with Framingham score, you see that the scores are generally much higher, and the risk is much higher. Renal risk scores has been already alluded to this morning. And fracture risk scores, I think we need to put our estimates of risk on an objective basis as well as we can. And also there is a nice tool for calculating the risk of reactivating latent tuberculosis in people with a positive skin test or a positive interferon gamma release assay, which I'm showing here. You could get the data. I'm sure you can have a look at the slides later on. But what I want to say is, we are automatically, as people who see the patients very frequently, we're automatically in the situation of being the spider in the web of treatment for our patients, or the Spider-Man in the web, if you want to say. So we have focused originally on HIV monitoring, but we've inherited all those other aspects of treatment, because people who see us every 3 to 6 months, they will trust us. They come back because they trust us. And they do not see their primary care physician nearly as often as they see me. So I automatically inherit the task of caring about the other aspects of their health. And what we need to realize, I think, is sustained HIV suppression isn't everything. We know that, and we've heard that in many presentations today, but everything else is nothing without sustained HIV suppression. So we mustn't forget that HIV monitoring is still the prerequisite for the patients not having the problems with HIV and having other problems. So I think for the future we will need a paradigm shift. I think the paradigm of HIV care is now shifting away from treating and preventing HIV/AIDS complications to achieving long-term health. And I think I'm very happy that this workshop exists, because it has the aim of promoting health as a principle of HIV treatment. And this, in my view, requires managing risks rather than disease once HIV suppression has been achieved. And the aim should be comprehensive care. No matter how you want to organize this, I think you can do it with subspecialties. You could send people everywhere and just do the HIV work. I probably could not do that. I have to learn again to treat and diagnose and treat and monitor all those other diseases. I think what we can say is in the initial phase, especially in people with advanced infection, we'll still focus on HIV-related risks to get people out of the mud first. But on suppressive ART after immune reconstitution, we probably have a shift of the focus of importance to the other fields that I've mentioned in the previous couple of slides. One aspect I think we need to think about in the future is in which way we can incorporate e-health into our treatment concept. And I think what we are lacking is a good tool to monitor adherence. We know how important adherence is. About half to two-thirds of patients in clinical trials do not fail because of true virological failure. They fail because they don't take the drugs. And these are hand-selected patients. So how do we actually measure adherence? We could sit down and count pills, but people won't bring back their supplies. We could have memcaps, which is not a practical thing. Or we could try to implement novel systems, adherence reminder systems, or even web-based systems, monitoring systems for adherence, which give people a reward for entering the data about their adherence. And this could help to manage polypharmacy by displaying drug-drug interactions even in the mobile phone of a patient, even maybe in a simpler way than the Liverpool database. It could help with refill orders and assessments of side effects. And we could have remote consultation and web-based information services for education. I think wearables and portable sensors are taken from this publication, don't play such a role in HIV. We don't have a mobile viral load monitoring system that automatically sends the data via the web and lets us control it. So I think, how should we approach it? I think along the questions that I've tried to pose, we have to develop a monitoring strategy, each one of us, for himself or herself or the institution we're working in, and select the appropriate screening and monitoring tools according to the patient's profile, clinical stage, nadir CD4, co-infection, all this stuff I've mentioned, age, gender, and drug use, as well as the virus in terms of resistance or replicative history, as well as the regimen because of drug-associated risks and toxicities, and not to forget availability in our settings. Much of what I'm saying might be irrelevant for some of the settings of some of the delegates, and I think we can discuss this tomorrow in the breakout sessions, because you don't have access to some of the diagnostics. We cannot perform bone mineral density measurement routinely in Germany. We have to have specific reasons. So it's a clear access barrier for us as physicians, so we need to think around this and find a way to still have adequate monitoring. And that's what I would like to ask you, to develop this strategy for yourself, for your institution, and try to even standardize it to a certain extent. And examples of that could be that you could consider prolonging the measurement intervals for HIV RNA or CD4 cells in people with long-standing suppression, a good adherence in the past, or people with a good CD4 reconstitution. You might even think about omitting CD4 count measurement in people who have long-term suppression, but that's a little bit provocative right now. Or you might as well think about controlling viral load more frequently, even at very short intervals, in people who are viremic on a low genetic barrier regimen. And I think most of the people who are active in the field of virology here, and most clinicians like myself, would recommend doing that. I haven't talked about diagnostics, and I'm not going to do that, and about epidemiology, but all this data is going to be very useful if you capture it in a standardized way to assess the epidemiology of HIV care. But pre-exposure prophylaxis, I think, is going to change the way we are treating patients, because the treatment of a pre-exposure prophylaxis patients is not very much less work than that of a stable HIV treated HIV patient. And we need early HIV diagnosis, very early HIV diagnosis. We need alarm mode HIV diagnosis for doing PrEP. And we need a very low threshold viral load testing. Ideally, I had a patient recently with a first positive ELISA on PrEP. And I called the lab and said, perform an HIV RNA from that sample. They did, it was negative, but still the question remains, was it negative because the patient was still taking 2 nukes, or was it negative because it's too early in the course of infection? You can't tell. So this requires a lot of alarm mode thinking in these patients in order to prevent resistance. And I think, as I said, one of the challenges for the next time, I hope we're going to have tools for that, is improve the detection of resistance at very low viral loads, because we're not switching when people have more than 1,000 or 500 viral load. We're switching when people have confirmed viral loads above 50 when they are on a low genetic barrier regimen. And we would need tools to assess the resistance in these cases in a reliable way, as well as I said, in switch patients when we have no virus to assess. We need to know if we can find this with a high enough sensitivity in PBMCs. So what's the future? Sorry, yeah, just the future. A look into the crystal ball. I think patient monitoring will, with an undetectable viral load, be based on a broader health concept. Individualization is still the principle, but standardization of procedures will help to avoid mistakes and missed opportunities. And I think we'll most likely increasingly support our subjective impressions of patients by validated tools for depression, life quality, and suicidality. Use of electronic tools, I think, could lower the barriers, and PrEP, I said, is going to be a lot work and lowering of barriers. Thank you very much for your attention.